JUVORA and Invibio is making really a huge effort to introduce PEEK into dentistry. So in the last year, the interest for frameworks made of polymer is increasing regarding titanium or zirconia structures. So there must be some reason why the professionals have problems with these materials. So if we look to aerospace industry, in the last 40 years or 30 years, the amount of material used quadrupled. So we have increased a lot, and in dentistry it's nearly the same. So the question is why the industry is using this material. You see here two examples. There are screws, industrial screws, and this is the cage. It's a human implant in the back, and it's made of the same PEEK we are using, so it's very biocompatible, and PEEK was able to get away the titanium material in this kind of implants. In industry, PEEK is used because it's highly resistant against nearly all kinds of chemicals. It's only attacked by two very strong acids. It's hard and stiff, but it's at the same time elastic. It's strong. It has a good friction. Very good wear properties, and this is very exceptional for a material. It has nearly no fatigue. It's very hydrolysis resistant. That's for aeroplanes very important, and in health industry it's important that it's so biocompatible. So this is probably worldwide the first PEEK framework used on screwed-on implants as a fixed device, and we made it back to 2008. So how do we did that? So it was really a very difficult and time-consuming process. So it's the old-fashioned dental technician. We had to make a wax-up, and you see in the wax-up the shape, the inner shape of the PMMA veneers we used. Then we had to do the injection canals, the same procedure as the metal injection, and then after getting the revision off, so we see the product. It's not very accurate, it's not very precise, and the biggest problem was that in about 30% of the cases we had blowholes and we had fractures. Because PEEK, it has a crystalline structure, the curve of cooling it down is very difficult. And if there are tension, the fracture inside the revestment can break. So we had to repeat the whole process. And that's not really a procedure that we can tell the world to imitate it. So the biggest change, here's the example of this first generation. So we did the implantations as usual, and I just show you one case as an example for all the other cases we did. And we compare the situation from 2008 and 2016. We see we have really healthy tissue. We maintain the bone, and we have no corrosion on the implant abutments if we use chrome cobalt structures. So we always have corrosion on the titanium abutments, and I think corrosion may be one of the most important factors for peri-implantitis. Also, it was very, very nice, the information Miguel gave us before. And I think I can reassure some of these aspects in our experience with PEAK. That's how the prosthesis was doing. So after 8 years, we see here some wear. We thought that PEAK had a little bit more wear resistance than it really has. So we have patients that they have a very big wear because we also placed full volume PEAK crowns in the patient's mouth, and about 20% have really a too big wear that it's recommendable to use it as an occlusional material. But in this case, normally, in 80%, we have I would call it a physiological wear. So we like it because the prosthesis can adjust to the function. But what you don't want to have is this wear here with the red line, because it's too much. And what we will see 2 years afterwards, that the veneer will fracture because the occlusion forces change. We saw that in other works. And the bottom face, so in literature always we see works done recently, and all the works we take out of the patient's mouth and have some years in usage, they are not so nice. So we saw this appearance and we thought, okay, we have to do it better. So we let in the bottom surface PEAK on the surface and try to make the borderline between PEAK and composite or acrylic resin like a step, so a very definitive borderline. And now the most impressive part of PEAK is how bone works. And we see here the 8 years difference, and we have a lot of light here in the stage, if we can dim it down a little bit, so you can see this stable and natural bone after 8 years. Normally we can see this kind of bone, healthy bone on ceramic fused to metal restorations or full zirconia. And so we did 9 cases from 2008 to 2011, and all worked the same way. And you see here in the beginning we had to glue the titanium abutment into the injectant PEAK framework. We had 2 failures of the cementation. You only can see it when you take the bridge off, but it generally worked very well. You see here in the case was 79 months. There's a small rejection of the gingiva. That's why we made an implantation, a flapless implantation with guided surgery, and so we really had from the beginning a too thin layer in the alveolar ridge upon the implant, but we see it stable. Okay, we see it stable. Another point, and that makes us even with periodontitis, I think a very important factor for periimplantitis is the bruxism, occlusal overloads, even in the natural ligament. And what we see in the patients with PEAK bridges in one jaw is that the other jaw increases over the years in health. Well, so to resume the good and the bad things, we had stable bone around the implants because PEAK has 24 times more shock absorption capacity than titanium, for example. So it's a good shock absorber. We had stable PEAK frameworks, we hadn't any fracture, and we had no chipping of these PMMA veneers. The bad thing, what we've seen, is the deterioration of the bottom surface. We had to learn to improve the polishing of the PEAK surface, and in some cases the wear and the occlusion. So that was I don't know why it was so big, but that is how our evolution went on. And there's Robert Ringy told, and I think Malot is doing the same, and even Elon Musk with his rockets. He has to take the same way. He says the way you learn anything, that something fails, and you figure out how not to have it fail again. So that's how we make approaches and improve it. And an interesting point is that there's no communication, scientific communication between the Malot clinic and me. So we do our separate ways, but you can see that in a lot of things we gain the same opinion. Okay, so I saw this PEEK material is a very nice material, so I started my dental lab. I'm a dentist. I started the dental lab in 2013. We started with a Roland machine. The Roland machine is not good enough for PEEK, so in 2016 we bought from Organical a machine specialized on PEEK, and now we have really extremely precise results. We will see that. And so from 2011 to 2017, we started the partial digital workflow now. Why partial? Because we still make silicone impressions. We don't use the intraoral scanner, but then we make our plaster model, we make our removable gingiva. Here you see it in blue. We make our design of the framework, and you will see that our designs from the beginning really are quite different to the approach of the Malot clinic. And here you see this milled PEEK bridge in the disc. We have nearly a shiny surface that's coming out of the machine without polishing. You can polish it inside the disc. And what you see is we make the connection to the multi-unit abutment totally in PEEK. But what we did is, and it was a difficult process, we made the PEEK that's beneath the head of the screw thicker, much more thicker than in titanium parts. And we saw that this works, and we have no opening of the screw hole, and we have no screw loosening and no screw fractures. We see that. So that's the process, and that's the second generation, and as I did in the first generation, I will see you a case. Here we have a patient, and we have this bridge from canine to canine that's not any longer sustainable. So the patient didn't want to have a removable bridge, so we made an all-on-4 approach with a drilling guide. And it's interesting, and I tell it because what we saw on the lecture from Miguel, the provisional bridge had a very rigid metal reinforcement inside the acrylic. And here we have the situation when we got this bridge off for the first time after 4 months. We have quite good gingiva, and we see this nice situation in 2017 and the stable situation. And this is the bridge. You see, we make really a full anatomically volume bridge, because for the big elasticity, we don't want to have the PEEK too thin. Okay, so we have an excess of flexibility. And also because we think that PEEK is the most biocompatible material. So this is the first bridge we made with the machined framework, and we were going on to put this PMMA veneers, multi-layer veneers on it. And we saw that now we had in the anterior regions problems for breaking off of the entire veneer. And we didn't have this problem on the injected frameworks. And we learned that the injected frameworks, with this analog workflow, we can give them another shape than with the machined one. So we thought, okay, how we can solve this problem, and we started to make it like the ceramic to metal fused system. So we designed our framework, we reduced it, and then we put our composite onto the PEEK, similar to the ceramics on metal. And that works really good. Since we do this kind of veneering, we have absolutely no fractures. So you see here in 2012 the first one, and the fracture this woman had always on the tooth number 32. So even if we left it a little bit out of occlusion, we had the fracture. We don't know if there are habits, okay, that if you have American ribs and you always chew it on the same side, we don't know it. But now it's interesting, with the composite veneering, we get stable results and good aesthetics. And you see the nice soft tissue. And now the X-ray, and that's really interesting. When I did my first lecture nearly 20 years ago, one person of the audience criticized me a lot. I was young and insecure, and it was my first lecture, that there was a tooth decay. You see it here on the 1.5, and I didn't treat it. Well, it's treated. So really, you see, this is before and this is afterwards. And now look at the bone. The bone, when we got after 4 months of integration, this metal bar provisional prosthesis are off, and after these 5 years with PEEK material, the bone improved. Nearly something impossible happened, that we have a better bone than before, especially in the tilted posterior implants. And that's what we see in all the other cases. Here's another case. I would like to show you a difficult one. And we placed these 4 implants. We had these 2 incisors to fix the removable denture. The removable denture did a lot of damage to the implants. So that's why immediate loading is something more favorable. So we had a difficult bone, a difficult situation, and we had some initial bone loss. And you see that we now not only do the PEEK abutment in cases of multi-unit abutments, but we do it directly into the internal hex of the implant. And so sometimes if we have a light disparallelism in between the implants, these bridges go inside because we can click them in because of the elasticity of the PEEK. And also we do these cases of the directly machined implant hex. We have no screw loosening, no screw fracture, and these PEEK hex resist perfectly. We have no wear there. We have sometimes black spots with an increased friction inside the implants, but there's no deterioration of this part. But what you see is on the X-ray that we have here the distance between this floating screw and the implant is filled up with PEEK. And it's not a thin layer here. That may be the explanation why it works. So now the results after 9 years. In black we have the situation of the first generation and second generation bridges, and in red the results of the second generation bridge. So in these 9 years we go on with stable bone around the implants. We go on with stable PEEK frameworks, okay, and really machining the PEEK, we increase the quality compared with injecting. So it's not a surprise. We still have no screw loosening and no screw fractures. And considering the second generation, we have no fractures of the direct to implant PEEK abutments, what I told you before, and the screws are working good. We always used a torque-controlled electrical screwdriver, and we place these screws with 15 Newton centimeters of force, so a little bit reduced as compared with the recommendations of titanium. But really we have no screw loosening. And what we always do is that the canal of the screw, we get it up to the occlusion. So we always, and we fill it up with Teflon and a thin layer of 2 millimeters of composite. So if we have to get it away, it's easy because with the diamond burr we can touch the PEEK, but with refrigeration we will not burn it, we will not hurt it, and then we have a really nice canal to get down to the screw, especially if we have long canals. If people with hybrid prosthesis come to our office, it's sometimes really incredible. The difficult is to find the screw in the acrylics. So the things we had to learn, which weren't going well, is we had this wear of the PMMR veneers. So now we know that with the composites, we use here the Gradia from GC. It's amazing the hardness of this composite, and if I adjust, or I have to adjust a little bit the occlusion in the mouth, the sensation is really like ceramics. And what was new is that we had this sometimes the chipping of the veneers of the sticked to the PEEK framework sticked veneers, and I think that's not the best solution in the machined frameworks. So we did a retrospective long-term clinical evaluation of our patients. So we had 25 patients, but we only could make the recalls in 21 patients, and all were treated with full arch implant supported screw retained bridges with the PEEK framework. And in these 21 patients we had a subgroup of 9 heavy bruxers. In 2 cases we replaced a ceramic fused to metal restoration with PEEK because we had implant loss, we had fractures of the ceramics, and it was really a nightmare. And now these patients are stable with the PEEK framework, and they are really happy. And a total of 96 implants, so you see we generally do all on 4 or all on 6. solutions. We have an average observation time of 56 months, that are 4 years or nearly 5 years, and the maximum is, as Marcus told before, nearly 9 years, and the minimum were 1 year and 2 months, and that's the state of the data end of December 2016. So we lost only one implant, so it's a 99% of implant survival rate. That's in our practice superior to what we have in the rest. All the prostheses survived. We didn't have to change. Well, we changed one because of the chipping, but it was just the chipping, and we wanted to try the new method. And we made panoramic X-rays, and we calibrated, it was a lot of work, we calibrated each X-ray to see the bone level, and we had an average bone loss from mesial 0.2 millimeters and distal 0.3, and this is really exceptional, and I think you could see it on these X-ray examples I showed you. In only one case we had a periimplantitis, and in one patient with 4 implants, 3 implants were absolutely healthy, and 1 implant had this bone loss. We don't know really why. And then we gave to all the patients a questionnaire, the OHIP, Oral Health Impact Profile, and the result was that the patients with these peak frameworks were extremely satisfied. And we had a score of 9.4, and that's superior to what we normally see in these studies. So why is that so? I think all the explanation of this success is inside the physical properties of PEEK. One is because PEEK is flexible and has a big elasticity model. The elasticity is similar to the sponge's bone. That means that we can always achieve a passive fit. Also, we have some minor errors in the fit. The PEEK is compensating it. And then the shock absorbing characteristics of PEEK are very important too. Another point is the low density. It's a very lightweight material, and it has a very low water absorption. So the water absorption is around 0.1. It's much lower than the acrylics, and we see that if we have to shape a PEEK that was during a big amount of time in the mouth, it's not has not a bad odor. So it's the same as the first day. And as we make implant-supported bridges, these bridges normally have a very big vertical, and so a big cantilever compared to the implant. And our bridges weighed about 10 grams. And I think it must be very comfortable for the patient to have something lightweight in the mouth. On the other hand, the flexural strength of PEEK is so big, so you have to bend it over 50% before it breaks. You can bend a framework on 4 or 5 or 6 implants 50%. So it's really impossible that there are fractures. And especially in the anterior region, and it's very important to have the minimum distance or growth of PEEK. So if we avoid this metal inserts, we gain in PEEK. And if we gain in PEEK, that means we can reduce the volume, and we have better aesthetics, especially in the anterior implants. And then the very good biocompatibility that shows us healthy soft tissues, and we have really no corrosion. And it's interesting, we are doing the same way as we are seeing in Malo clinic. So the third generation, and I don't have really data from more than 1 year, so I just want to present it, what's going on, is we make this framework, and we do very, compared to Malo, I think we do very thin zirconia crowns, and we do individual crowns, and so we have really bridges that we can bend, and they are flexible. So now we have, I think, all the positive parts together. So we maintain the flexibility and the shock absorbance. We have now a fully digital production process. That means these bridges take less time to produce than a bridge made of PEEK and the manual placed composite. And we can really adapt, so we can make aesthetic probes. So if we machine it before in PMMA, we can see if the shape is nice, and then we just have to transfer it to our zirconia clones. We see that we maintain the patient's comfort. We have now 5 patients with this kind of bridges, the third generation bridges, and it seems to do quite well. And here's the situation in the mouse. And here's a patient, what we see, we stopped to do hybrid bridges. That means acrylic teeth, acrylic upon PEEK. The union between the acrylics and PEEK is quite good, but what we see in the years, 4, 5, 6 years, is also we have a PEEK structure, we have these fractures of these acrylic teeth. And this was a work, it was done in another clinic, but the patient was so upset with these fractures that she said, if I knew that before, I go on with my complete denture and I don't want to have implants. Look how important this is. And I think with this third generation bridges, we really avoid this big problem. And another interesting point, as we can shape our full anatomic PEEK bridge, as we see it from the cavity or a cavity view, we can make it thinner. And when we placed this new bridge in her mouth, she brought us the plaster molar, so we just had to do a new bridge. She said, oh, I can speak better now. So although she was wearing during 5 years this hybrid bridge, there was no complete adaptation to the shape of this bridge. So the message is that you can't launch new ideas on old thinking. We started in 2008 with PEEK because we started in 2006 with zirconia implants, and our mind was open for a metal-free treatment approach. That's really the thing why we saw PEEK, and now we are happy, and we are not only doing PEEK framework bridges on our zirconia implants and do 100% metal-free restorations. So now we see that PEEK is the best material on titanium implants too. So thank you very much for listening. I hope you enjoyed it. And I want to say to my team in Picobello and the dental lab in my office, we are a lot of people now, and everybody worked very hard to make it possible for me to do this lecture. Thank you.